Hi, everybody.
Hey.
Hey, how you doing?
Good.
Hello.
I'm so glad to be standing because I've been sitting most of the afternoon. And in addition to being antsy from sitting so much, I'm also freezing cold. So this will help me wake up. I hope to wake you up too. I'm going to be talking about the person-centered primary care measure, which is a measure that my colleague Kurt Stengy and I co-created together out of the Larry Green Center, which we run. And I'm also going to be telling you about a platform that can be used to field that measure as well as others from a company called Smart Measures, which I co-founded with some friends. I'm an academic and I founded a business. That means I need to tell you I have a conflict of interest. It always humors me because my university requires that I reveal my conflict of interest. I get no salary or cash of any kind from this Smart Measures venture. We use the cash to support primary care, but I never have to share my motivations, just my conflicts. So I want to share with you my motivations. And my motivation is quite simple. I believe the pursuit of health should be a humane experience. And I think that should be true for the patients who are seeking it, and I think it should be true for the people who are providing it. So I work both sides of the fence on that equation, and that's what drives me and drives most of the work that I do with my team member. So first, I had this, the West Side Story, how do we solve a problem like Maria? How do we solve a problem like measures? This is something that I started to tackle around 2012, 2013. I'd actually go to CMS thinking that they would care, and I sat down and I'd say, so there are too many measures, they're not appropriate to primary care, and by the way, we all know that 80% of what affects health outcomes is social structures, so why would you hold medical care accountable for 100% of people's health outcomes? I don't understand that equation. And oh, did you know that most people come to get health care because they actually are unwell and seeking help? So wouldn't we expect that their measures might look, their quality indicators might look a little different? How do we solve this equation? Shockingly, the people I was sitting with in this room said, you know what, we actually find your reasoning compelling. So what's a measure we could use that would be better? And I said, oh my God, first of all, I wasn't expecting that. Thank you. Secondly, I don't know of any because we can't get it funded. You need first to say that you need such a thing. And if you say you need such a thing, then we have a receptor site, and then there might be a chance that we could find a funder who would help us fund that work. And I'll be damned if they didn't actually say that. Forever after, I believe institutions are hard and intransient things to move, but I also believe that the people who work within them are often trying to do good things, but they can't figure out how, and I try to help. I look for people's pain points and how can I help them. So they made it known that this was something they were interested in. We were able to work on it, and the message that I was bringing forth was it's about self-determination, which is very much what that NUCA model South Central Foundation is based on, self-determination. And measures are a way of self-determination. They're a way of self-definition. And when I sit in front of CEOs or policy people, I say, you know this. You have a job description and you have an annual evaluation. Do you ever feel good about your annual evaluation, and do you feel like it reflects the job that you do? There's usually a disconnect, right? It's like back in the 1990s, getting to sit with George Isham, who was then running one of the largest insurers, and complaining about the fact that he was at a meeting in New York and his reimbursements weren't covering the cost of his meal because they would only cover $55 a day. And I said, I know, it must really suck when somebody sets what they think is the fair price and you can't find what you need for it. So measures are ways of knowing. Right? They are ways of communication. We let people know how we value what it is that we do. We don't say to an architect, I will pay you based on how many pages of blueprints you produce. We don't say to a lawyer, I will pay you one rate for phone calls and a different rate for emails. We let them decide when email versus phone is appropriate, and we let them say what the value of these things are and what makes sense. It doesn't happen in healthcare. The way that we tell doctors they are important through these measures is exactly the most dehumanizing, unprofessionalizing way that I could imagine. So how do we create something different that actually appeals to the purpose of what primary care is about and to the reason why people seek it? That's what I was interested in. The last thing I said to them was, when you make a measure a target, it's never actually an effective measure anymore. It becomes a target. It's like the game of Survivor, right? And you get that measure by any means necessary. It does not promote professional behavior. So we wanted to change that. So then the next thing we had to face was this great divide in patient voice and how we pay attention to patient voice. And there is a divide here, and I gotta say, most of it is on the transactional side, and I live on the relational side. And when I, again, talk to employers about this, one of the things I say is, my whole life has not been in healthcare. I've worked in other industries. And here's what I can tell you. Working in one of the largest architectural industries in the country, when 9/11 happened, the first thing they did was not figure out how they could maximize virtual work with their clients. And some of you in here look young enough that you may not really remember what the impact of 9/11 was, and some of you look old enough that you probably do. But after this, I have to go from here to Dallas, and I had about 137 choices of flights that I could take. After 9/11, not a plane in the sky for days. It dramatically changed the landscape of our country in just a day. COVID dramatically changed the landscape of healthcare. Now, when 9/11 happened, our process was to actually call up all of our employees and say, did you have family in the building? Did you have friends in the buildings? Do you work with people who were in the buildings? How can we help you? What we didn't say was, I bet your inbox is really challenging right now. Let me come up with a solution for you. I bet it's really hard to think about how you're dealing with all your client concerns right now. We'll create a team and we'll delegate so that you don't actually have to do the difficult work of talking to people and hearing what's going on with them. We'll let you just problem solve at the end of the story, right? There's a difference here. I like the relational side. It doesn't mean that transactional isn't important. I make light of it. It's very important. It's just not the whole equation. So in the world of patient voice, we pay attention to the transactional side. People call it patient experience, and so we think it means something. It's a really handy phrase. Patient-centered medical home was a really handy phrase. In the beginning, it really meant something, and now it doesn't mean so much. So experience is about things you can observe. They are about you being aware of an event. You know something actually happened. Did you get the referral? Were you given the vaccine? Was there a follow-up call? Again, for day-to-day function, these can be very important things. But if I'm talking about performance, if I'm talking about quality, and I understand if I'm getting good care, I'm less interested in whether I got a thing or a patient got a thing, and I'm more interested in what it meant to them. I'm interested in the perception. Perception is when we have an organized interpretation of that experience. And I, again, try to make that meaningful when I talk to CEO folks, and I say things like, you all have cell phones. You, I'm sure, have had a chance to have a problem with your cell phone, and you needed to call the 800 number for help. First of all, if they told you to check the website, it was the kiss of death. You didn't like it. You're not going to find any help on the website. Then you get on the voicemail system, and after you go through 27 minutes of the automated whatever, so you finally get to a person, they tell you they can't help you with your problem. It either isn't part of your plan, or it's not something they can do, or it's not available in your area, and then they ask you two really important questions. Have I answered all your questions? Is there anything else I can help you with today? And they get 100% on the customer experience survey. But what was your perception of that? If you left it with some agita, then it wasn't so good for you. That's what I care about. What does it mean to the person who's receiving the care? So I wanted to create a relationally based patient or person measure. They told me it couldn't be done, and that's when I knew I really had a good thing going. And I gotta say, standing in front of all of you and talking about it, you must understand, is extremely intimidating. Because I sit there and I listen to all the fantastic things you do. And you touch so many lives in so many ways. It's astounding to me. My world is a little smaller than that, but I want you to know that my world is about serving you. You are my constituents and the people I care about. So you can reach me anytime. I'm happy to help you out. But I would like to enable you so you can continue to do your good things. So I was interested in creating a measure that would make a difference. I did it the unconventional way. I talked to people. I asked open-ended questions. I collected 10,000 comments. Half of them were from patients. Half of them were from clinicians. And while I know the majority of primary care is delivered by family medicine, I happen to know general internists, and I really like them. And I know general pediatricians, I really like them too. And I like to pay attention to them. So we oversampled in those two fields when we were doing this, because it should feed everybody. I also believe that care should be integrated. But if we create evidence, problem and solutions specific to a discipline, it fails us on integration. It becomes not meaningful evidence for the other disciplines with whom we want to interact. So I also talked to behavioralists, I talked to pharmacy, I talked to social work, I talked to occupational therapy, I talked to anybody, I even talked to some actuaries. I mean, I talked to anybody I could think of, public health, that would be interested, and made sure that their pain points were fed into how we thought about how we put this measure together. When we had what we thought would work, we held a conference in DC. We invited 70 people who were all the C-suite people from all the alphabet soup places. NCQA, ABFM, all, Purchaser Business Group on Health, right? All the places that would be interested, some insurers, some world organizations. And I started it by saying, you all are here because of your ability to make decisions. You're here because you know what can pragmatically work in the system right now. Your day jobs keep you from doing what's right. So I'm going to ask you to check the day job at the door, and let's just think about what's right, and leave it to me to figure out how to make it work in your regular constraints. And again, they really shocked me, and they actually did that. And the resulting measure came from their willingness to all talk and problem solve it together. We then had to test it. We did that with 2,500 people. I was told by my statistician I needed 150 people to validate it. How am I doing on time? Am I doing okay?
You're okay.
I needed 150 people to validate it, so we validated it with 2,500 people. What we were doing was unlike anything anybody had done. There's no biomarker. There's no process measure. Does your doctor know you as a person? We had everyday language. Statistics weren't going to move this ship, right? Anybody who believes the right data is going to move a policymaker's decision is living in a dream world. A good story will do it, but not data. You need to have data or it's a no-fly zone. But that's not enough. So how do we make it enough? I needed to blow it all out of the water. You need 150, we will do it with well more than you need. When people would come to me and say, I work in an all Medicaid environment, I'm gonna get dinged for whatever, that's fine. I'll take 200, I'll validate it in your environment. I'm in an all Medicaid, I'm in a all pediatric, I'm in an all foreign language, whatever it was. You tell me you think it's not going to work, I will validate it in that environment alone. And I have yet to be able to break it. So it works really well. We got it validated for use in MIPS. It's been used in MIPS since 2022. It's been piloted by payers as well as employers in different health systems, and CMS just adopted it instead of its own CAPS measure, which they love and I hate. They adopted using it in the next two primary care pilots that are active. Making Care Primary, which is for 10 and a half years in 8 states, and ACO Primary Care Flex, which launches in January of this coming year. So it's gotten tremendous traction in a very short period of time. It really, to be fair, has not been tested well enough to have that much traction. I just tell a good story. But it's because they really believe, you're right, we want to make the pursuit of health a more humane experience. If this might do it, that's great. Yeah. So we try it. I'm not going to go into the science because I don't think you guys really care, but I'll just say there's some signals that this measure was kind of different. Factor analysis, if you have a 0.4 on all your items, that's a good sign. The scores go from 0 to 1. It's like saying 40%, your question overlaps 40% with what you're trying to measure, kind of thing. The scales that you usually get when you do a patient-reported survey, it looks like this. It's called an asymptote. Everybody scores 95% and above, with very few using the rest of the scale. And the context, somebody referred to this earlier today, the context is usually academic health centers. This little funky square diagram is from a series of studies called the Ecology of Medicine. And it was repeated like decade over decade. And that wider box, as the story goes, for every 1,000 people of our population in a given month, next box in, about 800 of them experience some sort of physical symptom. Next box in, about 350 of them seek care for that symptom. Next box in, about 213 of them go to primary care. Next box in, about 113 or less than 2% of that 1,000 actually go to an academic health center, but that's where most of the research is done. Yeah. So all the stuff we have is about what works in that tiny little box, in a tiny little situation. When we look at this measure, most of our things rate factor voting of over 0.8. It's unusually astoundingly high. Our psychometrician who did this work for us was one of the people who was on the APGAR score team. So not a fly-by-night. I don't know how to do the math. He got a Lifetime Achievement Award. I thought he was trustworthy. I asked him to do it. He said he'd never seen anything like it in his career. It was great. If you ask people what's important and then you include it, it turns out it kind of works. The scale gets a distribution. You still get an uptick on the end. You still get a lot of people saying positive things, but they use every point of the scale because the questions actually matter to them. So they read each one and answer it. And then we just tested the hell out of it everywhere. In fact, I was talking to somebody in the back about the OECD countries. We published an article, we tested this in all the OECD countries, converting it into the languages, the primary languages spoken there. It's now validated in those 30 languages, and they're all available for free on my website, See My Conflict of Interest. So this is the measure. Everything is rated on a 4-point scale. That is a spoken scale of definitely, mostly, somewhat, not at all. Give you a second to take your pictures. It's really commonplace language. I want to point out just a couple of things about it. It does not say this practice, it says my practice. It does not say my care team, it doesn't say my provider, it doesn't say the provider, it doesn't say the person I saw in the last 6 months, it doesn't say wherever Michael Fine is, he left the room, my usual source of care. It says my doctor. I get challenged about this a lot. I get wonderful people who are really well-meaning who say things like, what if their clinician is a nurse practitioner, won't they be confused? What if their clinician is a physician associate, won't they be confused? What if they're taken care of by a care team, won't they be confused? Nobody's confused. 10,000 comments, nobody used care team or nurse practitioner. They may have that. What they say is my doctor. It's the language that's meaningful to us in our day-to-day. The things that you care about with those terms, I would say, that's some feudal tribal thing that goes on in the disciplines, but the patients really don't care. They just want somebody to help them. So, how do we solve a problem like fielding? How much time have I got left, Larry?
Oh, you have 5.
Okay, I'll breeze through this faster then. The problem once we created this thing was how do you field it? And I'm going to be totally self-conscious about the fact that I'm being recorded here. And I'm going to say there are big vendors who help you with this problem, and they charge way too much money. Way too much money. An absurd amount of money. Tens of thousands, sometimes hundreds of thousands of dollars more than they should. And they give you no access to the data. They claim the data is theirs, that they own, and they share it for you in the way that they want and when they want, often 12 to 18 months after it was collected, at which point the person who was actually responsible for delivering the care may or may not work there anymore. And the person who receives the penalty or benefit for that performance may or may not have arrived a month ago. It's a crazy, crazy system. We decided to address these problems, address measurement. Now we need to address how do we solve a problem like fielding. It's unrealistic for patients. I don't know if you've ever had to take a CAPS yourself. I try to take surveys because I do surveys myself. I feel obligated. By the time I get to question 47, I really just can't take it anymore. How many questions can we ask that are absolutely pointless? Feedback delayed for months, don't own the data, you can't sort it. So they give you a number, they don't show you anything about the number, they design it around billing, so God forbid you have residents, we can't give you a score for residents, we can only give you a score for a clinician that can bill. We can't give you a score for a nurse practitioner, we can't give you a score for a social worker. What point is that? And we give you the score at the end of the year, how am I supposed to, I thought we were talking about performance and improving it. How am I supposed to do that? So we made the unexpected leap. We created a company to solve the problem. It's the 2 people on the top, my deputy director at the Green Center, and 2 guys I've known since high school that happen to be software developers and have been doing it quite successfully for about 25 years. And I asked them to help me solve the problem, and they did. And the cost of solving the problem was less than, say, Prescani would charge for 1 year of using their, sorry, shouldn't have said that, right? Okay. The company we created is Smart Measures. Smart Measures actually owns the person-centered primary care measure. It's available for licensing. For most people, the licensing is free. We do the licensing so that we can track who's using it and to what end, so that we continue the science of the measure. We created a platform that allows you to field the measure. We had DPC in mind when we created it, but it could work for anybody. But I'll tell you, we have one customer, my conflict of interest management plan, I can't talk to you about pricing. But I can tell you that we have one customer who's using our platform for all of their patients, and they pay $250 for the year.
Amen.
By the way, for that, you get to not only field it as many times, but you can sort it in whatever way imaginable. You can sort by the clinician characteristics, by the patient characteristics, whatever the hell you want. We have the personal health inventory. Somebody mentioned Wayne Jonas before. This is actually his creation. It redesigns how you deliver a visit. It's point of care versus the PCPCM, which is anonymous. Our platform can handle both. And we have a card study app. Card studies were the old-fashioned way of doing research in family practice. We created it so we could get clinician-reported information. That means, by the way, the next thing I'm working on, is a clinician-reported measure to hold health systems accountable for appropriately resourcing primary care. So you create your surveys, you can send out your campaign, we can do it on text or by computer. Pick your modality. You can monitor your results, you can watch it real time. We've run a demonstration in a room of 60 people. We had them sign up. It took us about 5 minutes to get everybody onboarded. 5 minutes. And then we had them all send each other the surveys, and we watched it just appear on the screen, real-time access to your data. Very easy. This is the email that you get to sign up. This is what patients see when they sign up. Yet some very short but important things. We list your doctor's name, their practice, so they know it's not spam. We then list basic information about you so that you know it's the right person, because if you have a family, sometimes mom is in charge and the survey's going out to a kid, right? So we let them know that it's anonymous. You get to see your score. You get to see each item in your score. You can see the actual number, or you can put it on a 100-point scale if you want. You get to see, you can sort it in any way, any timeline you want, any clinician markers you want, seriously anything. We're running out of time, so there's not much I can add, but I'll show you for each question. You can look at the demographics. You hover over one of the things, it pops up, it lets you know for that age group, here's what they said, here's the number it's based on. It's really handy. I would normally go through this to show you how we use the measure to change the conversation, but we're short on the time. So I'll just say, I can tell you later about the challenges we're hoping to face, but this is how you can reach me.
Awesome.
And I'm seriously here for you, so let me know how I can help you out. That's it.